Good afternoon, everyone. I'm Jen Kanakry. I am the new medical director here of the Stem Cell Transplant and Cellular Immunotherapy program. And I'm going to try to cover the very broad topic of cellular immunotherapy in a way that is digestible to you all. I have no disclosures. I was a federal employee for the last 10 years. The learning objectives are for you to understand the historical foundation of cellular immunotherapy and describe the different types of cellular immunotherapy, their applications, and their limitations. Appreciate some of the cautionary tales related to cellular immunotherapy. Understand key aspects of how to cultivate cellular immunotherapy because it is a living medicine. And if you want to read a very good book, read the book by Dr. Applebaum about this topic. And then finally, to gain insight into the curative power of allogeneic hematopoietic cell transplant, which is my first and true love, even in the day of much fancier cell therapies. Notably, I'm not going to talk about autologous stem cell transplant in this talk because it is not a cellular immunotherapy. So learn that. The therapeutic maneuver in autologous stem cell transplant is a really high dose of chemotherapy. That's the therapy. And it's so much chemotherapy that we wipe out their blood-making potential and have to rescue them with their own stem cells. But the stem cells are not the therapy, the chemotherapy is. So moving on to true cellular immunotherapy, allogeneic stem cell transplant was the first cellular immunotherapy to cure cancer. You know, we talk about CAR T cells and TILs and all these other things, but allogeneic transplant back in the 1960s was the first successful cure of blood cancer. This started with Dr. Donald Thomas at the Fred Hutch in Seattle, and his first many attempts at allogeneic transplant were wildly unsuccessful. Graft failure, horrible fatal graft versus host disease. People criticized him, scattered from the field. Really just a dramatic example of someone sticking with an idea despite tremendous failure and toxicity to patients. Of his first 54 patients, all of them died except for 6, but those 6 were cured, and he kept going. The first successful syngeneic transplant, which is a twin transplant, it's not truly allogeneic, was in 1960 for aplastic anemia, and then the first successful allogeneic transplant in 1968. And then his work in the field was recognized with the Nobel Prize in Medicine in 1990. So these are some of the diseases where we apply allogeneic stem cell transplant: blood cancers, what we now call inborn errors of immunity, but used to be called primary immunodeficiency diseases, hemoglobinopathies like sickle cell disease, thalassemia, and bone marrow failure syndromes. What do these all have in common? Why do we use allogeneic transplant to treat them? They're all defects in the immune system or the hematopoietic system, and thus that's what we replace when we do an allogeneic transplant. Just as a side note, we can also transplant inborn errors of metabolism because we can restore the defective enzyme and let it with the donor cells, but I won't get into that today. So those are the diseases we transplant, and it directly relates to our goals in bringing them to transplant for those diseases. Patients either need a new immune system or a new blood system. The most common reason is that they need a new immune system. And that may be because they have an immunodeficiency, an immune system that is defective or deficient. Maybe they have an immune system that is hurting their hematopoiesis, like an aplastic anemia. Or maybe they have a cancer that can't be cured by all the drugs and radiation and other therapies that we have. And we're giving them a new immune system because we're hoping that healthy immune system is going to attack and kill and cure their cancer, what we call graft versus tumor effect. Or they have a blood system that is defective, like in sickle cell anemia, and we need to replace their blood system. This is a nice timeline of the history of allogeneic transplant and where we've come over the years. where the first early transplants up until the 1990s actually were all high-dose chemotherapy, and then cells from a healthy donor. But it had a lot of the flavor actually of autologous transplant, where there's sort of this thought that dose intensity, chemotherapy intensity, sort of helping to get rid of leukemia, and then the donor was there to replace something that the patient didn't have, a healthy blood system or immune system. And so transplants were being explored for victims of radiation accidents, immunodeficiencies, blood cancers, leukemia mostly, and aplastic anemia. But then in the late 1970s, we started having experiences that were recognized that patients with leukemia who relapsed after allogeneic transplant went back into remission when they had graft versus host disease. Or if we gave donor lymphocytes, donor T cells to a patient who relapsed after transplant, that they would go into remission. And this is the first sign to the field that it's actually the immune system that is curing these cancers and the power of a graft versus tumor effect. And that also allowed the field to move away from this idea that you need to give high amounts of chemotherapy before transplant and explore reduced chemotherapy, reduced intensity approaches to transplant. And that was just in the 1990s. And then things have gone on from there, and we do tens of thousands of allogeneic transplants in this country each year. But there's CAR T cells, there's TCR gene engineered cells, there's TILs, there's gene therapy. So is allotransplant going out of style with all these new kids on the block? And so first I'll talk about the new kids on the block, but I'm going to circle back around to allotransplant. Except my slides don't want to advance all of a sudden. So you get to look at, there we go. So the newer things, CAR T cells, chimeric antigen receptor T cells with targets CD19 for B cell malignancies, leukemias and lymphomas, BCMA CARs for multiple myeloma, FDA approved CD19 in 2017, and then BCMA CARs in 2022. And at the NCI, I was very fortunate to be part of the BCMA CAR development, and gave the first BCMA CAR to the first human on this planet, and got to see a lot of the early toxicities of both CD19 and BCMA CARs. There are also FDA-approved TCR gene-engineered cell therapies, MAGE-A4 for sarcoma approved just last year, and TIL therapy approved for advanced melanoma also just last year. This is a nice timeline showing the race to develop CARs at Penn and at NCI, and the amazing work that was done to bring CARs to patients. And again, I was at NCI from 2015 on, and really got to be part of this development. Just a little primer on how are these different from each other. So CAR T cells are genetically modified, synthesized receptors that are built to run, and you put them in the patient and they start proliferating, targeting surface molecules on the tumor, and therefore HLA independent. T cell receptor therapy is also genetically modifies, but it genetically modifies a naturally occurring receptor. And so then those TCR cells need to be fed with growth cytokines like IL-2. What that allows, using a naturally recurring receptor, is it allows you to target antigens that are inside the cell, because they get processed and presented through MHC molecules. But that means that the patient that's getting the therapy has to have that HLA. And so it greatly restricts who can get that therapy, because we do not all have the same HLA. Tumor infiltrating lymphocytes are not genetically modified. They're literally dissected out from the patient's tumor by surgeons and then grown up and cultured in IL-2 and then given back to the patient. But all of these cell therapies do require that we knock down the patient's immune system, we lymphodeplete them, condition them before they get cell therapies. So there's sort of like a void that the T cells can grow up in. So just like an allogeneic transplant, all these patients get some chemotherapy right before the infusion of cells. When we think about how and when we can use adoptive cell therapies, the tumors have to have a target on them. And so the target has to be there to use the adoptive cell therapy. And it can also be a mechanism of later escape from the curative potential of that therapy. And we know that these therapies can induce really deep remissions, but the cells don't last in the body forever in most patients, and that lack of long-term persistence may make cure with adoptive cell therapies less likely, less reliable. You also have to be able to live without whatever is being targeted, because it's targeting on the tumor, but it's also targeting it on whatever cells in your body also express that target. And so people can live very readily without B cells. And that's why, B cell directed CAR T is really exploded. You can't live without T cells, though, for too long. You become like an AIDS patient and you die of horrible infection. So there's some limitations there when we think about the types of blood cancers that we can treat with adoptive cell therapy. And importantly, the target cannot be on vital, healthy tissues. And so when you're developing a targeted therapy like this, you have to show the FDA that you've tested against a huge panel of every healthy tissue in the human body and shown that that those healthy tissues don't express the target, or that they're not vital. And there's only so many targets like that, right, in the body. And now I'll talk a little bit more about it later, this idea that maybe there's T cell malignancies that can come out of adoptive cell therapy. Briefly about what we all classically call gene therapy, although these are all ultimately gene therapies. There is an FDA-approved gene therapy as of 2023 for sickle cell disease using CRISPR-Cas9 technology for gene editing. This is currently an ex vivo process, and so patients who get gene therapy for sickle cell disease have to get really high doses of chemotherapy before delivery of the cells. That's a huge downside. These are like autologous transplant levels of chemotherapy. And so the future, although we're not there yet, is in vivo delivery of the edited gene. So back to allotransplant versus all these other genetically modified cell therapies. To contrast the two, allogeneic transplant is, it's old, but it's still good. And what it offers that targeted therapies don't is a diverse donor immune system that can evolve over time, that persists forever, that responds to multiple targets, that can modify its immune response. It's also cheaper, and it's more available to anyone in need. In modern allogeneic transplant, we can find a donor for any patient who requires transplant. And there's not a question of, do you have the target? Do you have the HLA X, Y, and Z? And allogeneic transplant, because of its persistence, because of its diversity, has a reliable curative potential in many malignant and non-malignant diseases that I personally, as an allogeneic transplanter, first and foremost, think will never change the landscape of the future. For, like people say, allogeneic transplant is not going to be a thing anymore. It will always be a thing in my mind. And again, because adoptive cell therapy can only cure if all the target is killed in the time that the cells persist in the body. And then gene therapy can cure if sufficient marking is achieved. So what is allogeneic transplant? It is a process. It is a process, a very long process. And so you give conditioning chemotherapy to knock down the host immune system to be able to receive the donor cells. We call that day 0, transplant day, where we give the graft. And then we have to give medicines to prevent that donor immune system from coming into the patient, seeing a foreign space and attacking it, causing what we call graft versus host disease. And through all of that, there are many risks of this is a very profound immunodepletion and immunocompromise that comes with allogeneic transplant, and risk of death, risk of toxicity, risk of graft versus host disease. And all these things can happen, but as you get through it and you start to hopefully be able to peel off the medicines to prevent graft versus host disease, that's where the work of the transplant is being done, where you're wanting to get immune recovery. And through that, through the graft versus tumor response, disease control. And so it is this process of cultivation, cultivating what you've given on day 0 and having it grow up and function to provide the patient with the immune system that they need to be cured of their disease. So this is not like other therapies. It's a living medicine. Once you've given it, it's a living medicine inside the patient. You cannot just order it, give it, day 0, consider the job done. There is work that needs to be done under the guidance of a trained cell therapist. So how do we as cell therapists cultivate the donor immune system? We're trying to get the immune system back as quickly as possible. This prevents our patients from dying of life-threatening opportunistic infections and viral infections. And for those that are transplanted because they need a healthy immune system for one that's defective, it helps us get them that healthy immune system. For those that have cancer, it helps get them an immune system that hopefully will attack and kill and cure their cancer. We do need to prevent severe graft versus host disease because we have to treat that with immunosuppression. And again, that gets back to task number 1 of getting the immune system back. But the enemy of good is perfect. We do not need to treat all graft versus host disease, for sure. And some GVHD probably comes with a graft versus tumor immunity and is helpful. Some is actually essential as we do reduced intensity transplants where you actually need the donor immune system to kill off residual host hematopoiesis and allow full engraftment. And so you have to very carefully treat graft versus host disease, always asking when, if, and how long to use immunosuppression, knowing that you've transplanted them for a blood cancer that could relapse, and that is the major cause of allogeneic transplant failure for patients is relapse of the disease that they were transplanted for. And always asking, is immunosuppression helpful or harmful at each juncture? So transplant does not cure all patients. The major reason for failure is due to disease relapse. And really that comes through poor immune reconstitution, maybe unstable grafts, the double-edged sword of graft versus host disease and treating or over-treating graft versus host disease. Effects of prior therapy on the thymus and whether they still have the potential to generate new T cells from the graft, and then immune senescence and exhaustion, as well as some ways that the tumor can get smarter and lose some, have some immune escape as a mechanism of late relapse. So scary things, right? Graft versus host disease and severe immunocompromise. And so are we like is cell therapy scary? Are we giving poisons to our patients? And I would say no, but every rose has its thorn. And I'm actually going to talk about some of the thorns related to adoptive cell therapy that we are learning about. So we've come a long way. There's lots of really fancy therapies, but there are cautionary tales throughout the history of cellular immunotherapy. In 2014, a group that had given gene therapy to 10 boys with Scott-Aldrich syndrome published long-term efficacy. If you can get the gene therapy into the patients, they're cured of their Wiskott-Aldrich syndrome, but significant genotoxicity. At the time that they published this, 9 patients had been had successful gene transfer long-term. And when they published it, 8 of the 9 had developed a blood cancer. Many of them were T-cell leukemias where there was insertional mutagenesis with vector integration at LMO2 and hence the T-cell malignancies. And actually at the time they published it, there was already a similar story 10 years earlier than that, same situation in XKID gene therapy. The other thing that happened is they had published this right as I was treating the last patient on this study who had presented with a T-cell acute lymphoblastic leukemia and with vector integration at LMO2. And we tried to transplant him to save his life. He was a huge fan. His name was Mac, and he was a huge fan of video games, including the Fallout video games. And so they designed a character after him when they released Fallout 4. And so Big Mac is after that last and final patient where every single patient that got gene therapy got a genotoxic heme malignancy and died. Now we're learning very recently that CAR T cells are not without risk, and there's a risk of second tumors, namely T-cell lymphomas with the CAR gene inserted. More to come. This is all just, newly on the horizon. And another evolving cautionary tale in gene therapy, this is likely not, almost certainly not insertional mutagenesis, but an increased risk of AML in patients who got gene therapy for sickle cell disease. I'm going to shift briefly to talk about my last 10 years as a clinical researcher in allogeneic transplant, working alongside two doctors, Dr. Dimitrova, who's still at the National Cancer Institute as a immunologist and transplanter, and Dr. Camille Rashash, a hematologist oncologist, who has joined us here at Georgetown and will be part of the cell therapy team. And together over the years, we had a robust clinical research program looking at ways to enhance host lymphodepletion, improve post-transplant immune reconstitution to optimize cure and minimize complications in people with very rare diseases that required allogeneic transplant. And many of these patients that I'm going to talk about next don't have CAR options, don't have gene therapy options, don't have all these other options. And this is where allotransplant is really interesting. So when I came to the NCI in 2015, they had some focus on transplanting inborn errors of immunity, specifically a huge focus on GATA2 and DOC8 and chronic granulomatous disease. But at NIH, there were investigators across many institutes actually defining and identifying many other diseases of the immune system, and they were very eager to be able to offer a therapy to these patients, not just study them in natural history studies, but be able to offer them something. And so I came in, recruited to develop a cell therapy program for these patients with inborn errors of immunity, and then I went beyond that. And so many institutes at the NIH all seeing a whole range of diseases. There are over 500 monogenetic diseases of inborn errors of immunity, and taking those patients across these institutes to transplant under my clinical research program. If you want to see more about the work in cell therapy at the NIH, you And my first patient on my first clinical trial, which is very daunting now that I think about it, featured in the Discovery Channel docuseries First in Human, and that patient is still doing very well today. But it's a fun 3-part docuseries that you can watch if you're interested. So when I came there, I wanted to develop a program that could really transplant anyone who had an inborn error of immunity, knowing that these would be very heterogeneous diseases. And I wanted to develop an approach that would work for everyone. I knew transplant could cure them, while avoiding toxicity and optimally avoiding graft versus host disease. And so I drew from ongoing research in mice and immunotoxins and in other applications of transplant to build a novel regimen. And I selectively decided to avoid radiation. There are lots of long-term toxicities to that, to use a reduced intensity approach to spare these people a lot of chemo. And also because I wanted good immune recovery to avoid antibody-based ways of killing the immune system, and developed this novel platform that I then hoped would take all comers and lead to cure of their underlying immune system problem. So we transplanted many diseases on these studies. The paper on the right is the first 20 patients, but we've transplanted 70 patients to date, more immunodeficiencies than anyone else in the world. And we learned many things, that there were some diseases that are really hard to engraft. We also were the first to successfully transplant some diseases that had never been transplanted before or never successfully been transplanted before. We learned really interesting things about the role of the immune system in certain settings, like the role of NK cells in HPV-associated cancers. This was actually, NK cells were not appreciated to be as much of a role. We demonstrated to the field of doubters certain diseases really could reverse the entire immunophenotype of the disease through transplant. We also had a lot of patients who had dysregulated immune systems, and you're never going to make that better until you get them to transplant. But the field would often just turn away and say, they're too hot, we can't take them now. And we transplanted people with really active, out of control diseases and showed that we could get them safely through. We did also try some diseases that in the end we learned you can't reverse through transplant. There's probably something that's not actually in the immune system, in idiopathic CD4 lymphopenia. That was Dr. Fauci's patient too, so it was sort of a bummer to not be able to cure his patient. But in this published study of the first 20 patients, remarkably none had chronic graft versus host disease. All who engrafted had evidence of phenotype reversal, meaning cure for them, good immune reconstitution, low toxicities. And so this novel regimen that I developed worked, but we did learn that some of the diseases were very hard to engraft. And we did a lot of really great collaborations and exploratory research along the way, learning many things about these really rare diseases and interesting patients that give us insight beyond those rare diseases into the function of the immune system in general. I then went on to try to lower the toxicity even further. There's a medicine, MMF, mycophenolate mofetil, that we used to help prevent graft versus host disease. I sort of asked, is it really necessary? Is it really important? Because it does cause a lot of toxicity. And so I started whittling that down in a study, bringing it down halfway and then stopping it completely. And we showed that you can do this, and it does not affect the survival of the patients. It doesn't affect their recovery, their count recovery time. The incidence of graft versus host disease was not increased, and even their immune reconstitution and donor T cell engraftment was better. That work is still ongoing as well, with now the sort of third generation of the study with Dr. Dimitrova at the helm since Dr. Rashash and I have left. And she's shortening the conditioning regimen, continuing whittling down the MMF, whittling down the other adjunct immunosuppressants. And the PT-Cy, the cyclophosphamide, is the main drug that we use to prevent graft versus host disease. And my husband is also a bone marrow transplanter with a translational lab at the NIH, and based on his work, reducing the dose of Cy. So kind of trying to improve toxicity and outcomes even further. But as I mentioned, we did have some failures, some people we couldn't engraft that were very hard to engraft, and we wanted to learn from this and do better for those patients. And so I asked, how can I improve this platform for these hard to engraft patients? Should I just increase the amount of chemo we give ahead of time? No, I didn't want to do that. That increases toxicity. Should I add back radiation? It's pretty standard in the field to use radiation to get a graft in. I didn't want to do that. And so I turned to serotherapy and thought, okay, can I add that? And then we were using marrow grafts, but peripheral blood and grafts better. And so can I make a change there? And that's what we did. Talking first about what we did with serotherapy. So in the transplant field, everyone uses serotherapy to serve two purposes. One, as a T-cell killing antibody to lymphodeplete the host and allow for engraftment. But two, these are antibody therapies with very long half-lives. And so you give them day -4 before transplant, they're still around after transplant, and then they kill T cells, so they act on the graft. And the second purpose in the field is to act as graft versus host disease prophylaxis. And everyone's sort of interested in how to get serotherapy to serve this dual purpose better. But in my study, there was no chronic graft versus host disease and low rates of acute and good immune reconstitution. So I really didn't want it serving that second purpose of preventing graft versus host disease. And so what I did is I picked the serotherapy with the shortest half-life, horse ATG, and decided that I wanted it only to act on the host and not on the graft. And to do that, you just have to time it more distally, right? You have to push it out from the administration of cells. And I knew I wanted to do this in the patients that were hard to engraft. If you lymphodeplete the host better, you should get better engraftment. But then I was also thinking, at the same time, patients with T-cell lymphomas, they don't respond to chemotherapy. They have terrible diseases. They need allogeneic transplant, but they often can't get there. This is another group of patients where maybe we can make transplant better for them. And if you add a T-cell killing antibody as part of the conditioning, maybe you get better disease control. And there's a national call out for more prospective studies of allotransplant and T-cell lymphomas. So I focused on these two patients in two separate clinical trials with the hypothesis across both that if we distally timed the ATG, we could improve the host lymphodepletion and the engraftment, but not alter our good ability to prevent graft versus host disease. And that the distal timing would still allow the T cells in the graft to have good immune reconstitution and afford good phenotype reversal of immune problems, as well as good graft versus tumor immunity, allowing us to keep cultivating that graft. And so this is work done by Dr. Camille Rashash with a grant that he received from the American Society of Clinical Oncology, looking as we treated these patients at the amount of ATG left in their plasma as we conditioned them and took them through transplant. And these are just total levels in plasma by ELISA assay. And you can see, when we give it, the levels are high, and day 0 is the transplant day. They're lower, but they're not 0. And our hypothesis was that there's not enough around anymore to act on the graft and kill T cells. So the next question was, the levels are lower, but they're not 0. So are they still cytotoxic? Or are they still able to kill T cells? And so then Camille, with the help of my husband's flow lab, flow cytometrically quantify the amount of ATG binding on day 0 in healthy cell subsets. And what we found is that on day 0, the amount of ATG left in these patients was not significant enough to bind hematopoietic stem cells and then key parts of the immune system like natural killer cells, CD8 and CD4 T cells, regulatory T cells. And there's ongoing work to further understand how the PK and PD and how to optimize this. And then back to the hypothesis, did we improve lymphodepletion and improve engraftment while not altering our ability to prevent GVHD? And the answer is yes. In the first study on the left, we had a graft failure rate of 6%, and there were these two diseases in particular that were very hard to engraft, where 33% of APDS patients had graft failure and 100% of DATA2 patients had graft failure. But in the new study with ATG, we got rid of this problem in APDS and still struggle with DATA2, but at least only a third instead of all patients having graft failure. And our rates of graft versus host disease did not change and still remained very low. And then the second hypothesis, would the distal timing allow us to still cultivate that graft and get us the immune system that we needed for graft versus tumor immunity and phenotype reversal? And in the T cell dysregulation study, all engrafting patients had evidence of phenotype reversal of their immune system problem. And in the T cell lymphoma study, we transplanted 20 of those patients had active refractory lymphomas. They went into transplant. And of those that went in with wildly out of control disease, 50% are still alive and free of their lymphoma. And the immune system recovery was very good. This is a little snapshot of the results of that T cell lymphoma transplant study. It is hopefully about to be accepted for publication any day now. But this shows the patients that will be presented in that paper. For the lymphoma doctors in the audience, they'll see the range of T cell lymphomas, and these are like gnarly, horrible diseases that are really bad. And then the heat map, each row is a patient, and the heat map shows that orange or yellow sort of bad features of either their disease or their underlying risk of dying through transplant. And everyone has at least something, if not multiple factors that weigh against them. And yet our outcomes in this disease population were very good, with a 3-year overall survival of 61% and 52% of patients being alive and disease-free. The only other prospective trial of allotransplant for T cell lymphomas was in a similar number of patients, 28 patients, notably different in that they were all in remission. So a much more carefully selected group of patients, and our PFS and OS are actually better than theirs. I'm going to end with a couple graft versus tumor illustrations to get you really excited about the curative potential of allogeneic transplant. So this is one patient with T cell lymphoma who really had like leukemic involvement. When we looked in his blood at his T cells in his blood, 80% going into transplant were his lymphoma leukemia. So active, readily measurable disease going into transplant. And then when we transplant patients, we can look at the graft, the donor cells, in something that we call chimerism. And so we can look at the percentage of donor T cells, CD3 T cells versus patient. And so when we recovered counts at day 16 after transplant, we took our first look, and my heart sank because his donor T cell chimerism was 0. And I was like, oh, crud. He doesn't have a donor immune system. At the same time, we looked, though, in his blood, well, what are all those lymphocytes in his blood? And they were all his lymphoma, or mostly his lymphoma. And so the blue line is flow cytometric quantification of his lymphoma, and the black line is donor cells in his blood. And what you're seeing, right? Like, how do you get rid of the lymphoma that's there? Well, as the donor T cells come up, the lymphoma goes away. That's graft versus tumor immunity that we could watch fascinatingly in his blood. I have gray hairs, though, because of it. This is another patient that I transplanted with a really, really aggressive refractory T-cell lymphoma, where like golf ball sized lesions would pop up all over her body in a matter of days after stopping chemo. So really high, fast-paced disease. Took her to transplant with all those golf balls. And she's now 3 years out from transplant, doing well, perfectly clean PET scan. Didn't even have any graft versus host disease, which is kind of fun. Showing that you truly can disentangle graft versus tumor from graft versus host disease, and doing very well. And these are all patients that would have been turned away from any other transplant center, and they would be dead because they didn't have enough disease control to be offered transplant. And then the final patient who had T-cell lymphoma lesions that we could follow in his skin. And when he was about 40 days out from transplant, one of the lesions started getting really heaped up and it grew this little mountain in the center. And I was like, oh gosh, like what's happening with his lymphoma? And so we biopsied it, and that's what that little biopsy mark is. And look at the dates, right? And so we biopsied it and then watched over time. And look what happened to the lesion. We didn't do anything else except the transplant we had done 2 months earlier. And in a span of 5 weeks, it all flattened out. And he's now continues to this day free of his lymphoma. At the same time, in his blood, we started seeing changes in his immune profile. And there are all these gamma delta T cells like exploding in his peripheral blood. And that's the track over time donor gamma delta T cells. And this is the biopsy, the skin biopsy out of that mountain that raised up in the center. His tumor is CD4 positive. The brown in the center picture is his tumor, which is also CD25 positive. So you see in that biopsy that we took when we saw this change in his skin that there's tumor there, there's lymphoma there. But then also there's CD8 cells in red, and those are gamma delta cells that express CD8. And those are crawling in from the deep side of the cut, from underneath, crawling in. And his tumor went away. So that's graft versus tumor effect to cure his lymphoma. We didn't do anything else other than transplant him and then cultivate, right, that immune response. So with that, I will close and say how excited and energized I am to be the new medical director here at Georgetown. We currently have a robust FACT-accredited program offering autologous allogeneic CAR T TIL therapy to patients with cancer in the DC metropolitan region. And we are going to lead the way offering these therapies to everyone that needs it. It's a tremendous opportunity where Georgetown is really well poised to be the dominant force in the area. But in doing that, really building up the clinical staff to provide excellent subspecialty cell therapy level care within a general hospital, but a great general hospital where the philosophy of care is to take care of the whole patient. Well, you definitely have to take care of the whole patient in cell therapy. And then I love educating people, and there's a lot of multi-D care that goes into taking care of cell therapy patients, need for consultant input and everything else, and really looking forward to interacting with everyone within internal medicine and beyond to talk and have collaborative dialogues about how to care for these patients. And then really having a fantastic group of nurses already involved in cell therapy, where Don Thomas, the father of transplant, really appreciated the importance of cell therapy nurses. He created his own ward because he didn't trust the care of his patients anywhere else. And key was the nurses taking care of those patients, and called them a secret weapon. And it really is true. You have to have subspecialty trained nurses to take care of these patients well. So, oh, sorry, and just really exciting opportunities to do research here as well. And so let's identify problems in the field, generate hypotheses, do the studies, and have fun, not just giving the standard of care, but defining the next standard of care for future patients. And I know there are a lot of people out there, hopefully in the room, who are interested in cell therapy for patients that they see, malignant or non-malignant. And I'm really excited to partner with all those people to talk about how we can do cell therapy for a broader range of patients, breaking down some of the barriers of cell therapy, but making it safe and less toxic, effective, and more available to anyone who needs it. And my last comment, yeah, so it's a living medicine. If you encounter a patient here at Georgetown with a living medicine, a cell therapy inside of them, and you have a question, just call me. I like to always be available, and to be a cell therapist, you have to be just very involved in everything that's going on with every patient, and that's my way of operating. And for sure, if you think you want to give steroids or anything that's going to kill my cultivation and my living medicine, you call me and you ask if you can do that. And so with that, I will close.